All right, let's get right into it. If you've ever held a laparoscope, you know the feeling. When we talk about complications in a lap chole, our minds immediately jump to one big, scary thing. But today, we're going to have a different kind of conversation. Think of it like we're in the surgeon's lounge after a long case, just talking shop. We're going to look past the obvious and explore all the other pitfalls, the ones every single surgeon needs to have on their radar.
And this right here, this is the whole point of our discussion. Yeah, bile duct injury is the one that gets all the attention. It's what we all have nightmares about. But, focusing only on that, it's like preparing for a storm by worrying about the wind but completely forgetting about the flooding. The reality is, this bread and butter operation has a whole bunch of other curveballs it can throw at you, and frankly, they're a lot more common.
So let's just walk through them. We're going to look at the things that can take a routine procedure and turn it into something much more complicated. And we're going to start with the single most common complication of them all: bleeding. Now, in open surgery, bleeding is a volume problem, right? You can see it, you can pack it, you can put a finger on it, but laparoscopically, it's a totally different beast. Bleeding isn't just about blood loss, it's a direct assault on the one thing you can't work without: your vision. And it can come from anywhere. You can have that maddening, persistent ooze from the liver bed that just smudges up the whole screen. Or you can have that heart-in-your-throat moment when a clip slides off the cystic artery and suddenly there's a pulsating jet of red painting your camera lens. Heck, you can even cause it just by putting in the ports if you're nicking up a gastric vessel. So here's the bottom line. The second your lens is covered in blood, you are flying blind. You can't dissect, you can't see the anatomy, you can't even find where the bleeding is coming from. That one fact changes everything. It means even a tiny bit of bleeding becomes your #1 priority. There's some real wisdom in this from the surgeons who pioneered this stuff back in the 90s. They got it. The first thing they taught the junior surgeons wasn't the anatomy, it was crisis control. How do you stay calm, get your view back, and take charge of the situation? Because they knew then what we know now. A foggy scope plus active bleeding is a recipe for pure panic.
Okay, so let's shift gears. The next set of complications, these are a little sneakier. They're the problems that don't necessarily show up right away on the table. They're more like a shadow that creeps up hours or even days later.
Bile leaks aren't always some huge, dramatic transection of the main duct. Most of the time, they're subtle. Maybe a clip on the cystic duct stump isn't perfectly seated. Or maybe you singe one of those tiny ducts of Luschka in the gallbladder bed. The ones that aren't on any diagram. Little things like that can lead to big problems after the surgery if you're not absolutely meticulous.
So, let me ask you a question. We're in a tight space, using these incredibly powerful energy devices. What's the danger when you can't see every single millimeter of that tool? This gets us to one of the most feared hidden dangers in all of laparoscopic surgery.
And this timeline is just chilling. A bit of stray energy from your hook just kisses a piece of bowel for a split second. Doesn't look like anything. The patient goes to recovery, they seem fine on day 1, maybe even day 2. But that burn has started a slow, silent process of tissue death, necrosis. And a few days later, it perforates. Suddenly your patient has raging peritonitis and sepsis, a total catastrophe from something that was completely invisible during the case.
The lesson here is so simple, but it's everything. It's a mantra you have to have for every single case. Respect your entry, and always respect your energy. You have to know where every last bit of that current is going. Now let's pull the camera back a bit, away from the gallbladder itself, because the dangers aren't just in the dissection. They can come from the very tools we use and the environment we create to do the operation in the first place.
Believe it or not, your ports, your gateways into the abdomen, can come back to bite you. You can cause a nasty bleed if you hit an epigastric vessel. That's why transilluminating the abdominal wall is so important. You can set a patient up for a future hernia if you don't close the fascia on those bigger 10mm sites. And of course, the port can be a source of infection, or worse. In that rare case of an unsuspected gallbladder cancer, it can be a site for metastasis. That's why we're all so careful to use retrieval bags and not rupture the gallbladder.
And speaking of spilling, don't ever blow off a few dropped gallstones. When that gallbladder tears and stones go everywhere, it's not a trivial thing. We're talking about abscesses, adhesions, even draining sinuses that can show up years down the road. The rule is simple: get every single stone you can see.
This number, this is your magic number. It's the standard pressure we aim for with the CO2 insufflation.
You want it high enough to give you a good working space, but not so high that you're putting the patient's body under a ton of stress.
Because you have to remember, you're not just operating on an organ, you're operating on a whole person. That pressure can drive up their CO2, it can cause arrhythmias, it reduces blood flow back to the heart, and in the absolute worst-case scenario, you can get a gas embolism. This is a team sport. You have to be talking to your anesthesiologist constantly.
So when we put all of this together, you start to realize that avoiding these complications isn't just about having a technical checklist. It's really about developing a surgical philosophy, a way of thinking.
I mean, look at this list. We've talked about bleeding that can blind you, subtle leaks and hidden burns, problems with the ports themselves, spilled stones, and even the stress on the patient's heart and lungs. It is so much more than just worrying about the common bile duct.
And really, what this all comes down to is respect. Simple respect for the procedure, for the patient's physiology, and for all the ways things can go wrong. It's funny. This little, seemingly routine organ has an amazing way of teaching every surgeon who touches it a big lesson in humility.
And I want to leave you with this last thought because it's so true. When something goes wrong, it leaves a physical wound on the patient, but it also leaves a wound in your memory. The goal isn't to be a surgeon who never has a complication. That's impossible. The goal is to be a surgeon who learns deeply from every single one. If you can learn from both of those wounds, that is how you really grow.